Good morning, good afternoon, good evening, everyone. We'll give another minute or so and then we will get started. Thank you. Hey, everyone, it's 2 after the hour, so let's go ahead and get started today. Hi, everyone. Good morning, good afternoon, good evening. Thank you all very much for joining us today for the third session of Momentum's webinar series, Strengthening Analysis and Use of Routine Health Facility Data for Maternal, Newborn, Child, and Adolescent Health. We're really excited to have you joining us today and welcome you to introduce yourselves in the chat. My name is Emily Stammer. I am a Senior Research Monitoring and Evaluation Advisor with Momentum Knowledge Accelerator, and I'm really happy to be here with you all today. Before we dig into today's subject matter on data triangulation and analysis, I just want to go over a few housekeeping items in order to provide everyone with the best experience possible on today's webinar. Next slide. First, note that today's webinar and all other sessions during this series will be recorded and posted to the Momentum website. So if you're not able to attend all of the sessions for this series, you will be able to access the recordings and materials shortly after sessions take place. During today's session, some of the presenters will speak in English and others in French. We have simultaneous interpretation available for all sessions in the series. And I'd like to invite you to take a moment now to locate the interpretation icon at the bottom of your screen and select the audio channel that you would like to listen into for today's presentation. If you stay in this main channel, you'll hear the presenter speaking directly in the original language. About 1/3 of today's session will be in French and 2/3 in English. So on a related note, the slides that will be presented on the screen today will appear in the language in which the presenters are speaking. My colleague Zach will share links in the chat to the English-only and French-only versions of the slides so you can follow along with the presentation. We'll aim to give some verbal cues to note when to progress to the next slide. And then lastly, there will be a single break for questions and answers during today's session after all the presentations are complete. Please click on the Q&A icon at the bottom of the screen to submit any questions that you may have. We'll do our best to respond to questions either directly in the Q&A box or during our Q&A break. And then with that and with housekeeping out of the way, I think we are ready to begin. Next slide. Oh, there we go. Thank you. So the purpose of this series is to introduce participants to resources and tools that you can use to strengthen the analysis and use of routine health facility data for maternal, newborn, child, and adolescent health programs in your work with country stakeholders. Routine health facility data is an important source of information for decision makers to understand service utilization and service quality so that they can identify problems and make evidence-based decisions on policies and resource allocation. In an effort to strengthen the analysis and use of health facility data for MNCAH programs, the World Health Organization developed a guidance document and an accompanying resource package to be used for capacity strengthening in workshop and webinar settings such as this one. So the guidance document describes a catalog of indicators for MNCAH that can be monitored through routine health information system data. It also provides guidance on analyses and visualizations for the indicators. The document also, or the package also includes considerations for program managers for interpreting and using the data for decision-making purposes. The Momentum Knowledge Accelerator project has adapted those materials for this Training of Trainers webinar series. So during the series, we'll dive into the different components of the WHO toolkit to show participants how to access and use the resources. My colleague Zach will share a link in the chat where you can access the guidance document and accompanying resources. There's also a link in the slides that you'll be able to use to access the webpage. During this webinar series, you'll also hear about other practical examples from Momentum projects to help illustrate how the concepts covered during the series can be put into practice. And we'll highlight some existing resources, including tools and templates that may be helpful to support your work. So just a note, while some of our colleagues from the Momentum Awards were involved in reviewing some of the materials presented today, and we can answer questions about the subject matter itself, we personally were not best placed to answer questions about why certain content may have been included in the toolkit or excluded. For those questions or others, I invite you to reach out to the WHO using an email address that we can provide to you. Let's see, maybe Zach can put it in the chat. Just a note, I have actually reached out and asked questions before, and they are very responsive. So let's go. Next slide. During today's webinar, we'll be looking at components of the 4th and 5th modules of the toolkit, which cover data triangulation and analysis. We'll cover data interpretation and use in our session next week, and we will discuss data visualization in a sort of bonus session that will take place on September 26th. So stay tuned for that. Next slide. Just a reminder that each session in this webinar series has a similar structure and includes the same core components. We begin by introducing participants to key concepts related to the session's topics and highlight different tools and resources that are available to support your work in these areas. We focus largely on the WHO toolkit, but as I said, we'll highlight other key resources at the end of the first presentation. We'll then hear presentations from staff from different Momentum Awards and other external groups on how they've put these key concepts into their work and suggestions or lessons learned that they can share with you. Today's session, as I noted, focuses on data triangulation and analysis. If you missed the first two sessions, the first session covered an introduction to health facility data with a focus on MNCAH indicators. And the second session focused on data quality considerations when working with MNCAH data. And these presentations and recordings in both English and French can be accessed on the page dedicated to this webinar series on the Momentum website. Next slide. So today's presenters include myself, Adriana Almagnana, who is a Senior Technical Advisor for Immunization at JSI, and Jean Dorville, a Data Manager with Momentum Routine Immunization Transformation and Equity, joining us from Haiti. Next slide. So I'd like to talk a little bit about the objectives for today's session. Today, we're hoping to provide an overview of data triangulation and analysis and key points to keep in mind when supporting your partners working with routine MNCAH data. We'll highlight tools and resources that can assist with supporting partners to triangulate and analyze routine data. And then we'll hear from Adriana Almagnana about her experience triangulating immunization data in Ethiopia and the tool they developed as part of the UIFHS project. And then we'll hear from RHIS with John about their work supporting analysis of routine immunization data in Haiti. Next slide. So now I'd like to dive in and provide an overview on today's topics, which include data triangulation and analysis. So many of you are probably very familiar with data triangulation, so I won't spend too much time on the background here. But when supporting local partners and country teams, this background on triangulation is important to cover, just to give your teams a good idea of what it is and why it's important. The process of triangulating data is essentially just synthesizing existing data from two or more sources to help address questions for program planning and decision-making. Triangulating data from different sources is important for a number of reasons. Triangulation helps us corroborate findings, confirming or challenging our initial set of findings based on a single source. Triangulation can also help maximize a data source's strengths or make up for any weaknesses it may have. For example, if one data source is broad yet lacks detail in certain areas, and another is detailed but lacks the breadth, you can use the two together to tell a more holistic story and make up for each source's weaknesses and leverage its strengths. Additionally, triangulation can also help provide a clearer picture for evidence-based decision-making. Looking at, say, immunization coverage combined with conflict data may help tell the story that conflict affects immunization uptake, or that perhaps by triangulating supply data with coverage data, you can see a relationship between the two and can help inform policy and programming. Next slide. So in terms of MNCAH programming, what can we use data triangulation to do? We can use triangulated data to do the same things we do with regular single source data to begin with, like looking at the current performance of the health system and identifying gaps, or just to evaluate the impact of programs on MNCAH outcomes. But the addition of different sources allows us to gain a better understanding of the context in which programming is taking place. For example, weather or crop yield data could be triangulated with child health nutrition data to examine trends and better understand the context. Or by triangulating health facility data with survey data, you could better understand barriers to, say, antenatal care, uptake, or delivery in facilities. Additionally, triangulation can improve confidence in your findings and promote rigor. Checking your findings and trends with one source against another can help validate your findings. If you find that, say, with one source, ANC coverage in your population over the time period is rising, and then you look at another source for the same population and same time period, and it indicates that your coverage is declining, you know that there's likely a problem with one or both of the sources, and it really forces you to investigate more. Alternatively, if coverage is similarly rising in both your sources, you can feel better that the trend may be accurate. Finally, reviewing data from different sources enhances the capacity for critical thinking, data analysis, and use of data by encouraging review and use of diverse sources. So by looking across multiple sources, you're getting a better idea of the context and taking a critical look at this bigger picture, which honestly can only be helpful for better understanding a situation or context. So we'll get into this more in a future slide. But I'm interested and curious about what secondary sources you all may have pulled MNCAH data from in the past. If you want to put those in the chat, what sources have you used most commonly, and what are some of the rarer sources that you've used? I'm interested to see. I have pictures here on the slide depicting household surveys, supply chain data, weather data, and conflict data. I have to admit, I've only used the conflict data once, but have probably used household surveys, like I see some are saying the demographic and health survey, to triangulate with health facility data the most. Yeah, I think DHS is the biggest source that I've used as well. Great. Oh, and the spa, yes. Next slide. So how can we support our teams to triangulate data? As with any analysis approach, you want to encourage your teams to sit down and plan it out first. Make sure that your teams, your partners work through a planning cycle. The cycle presented in the WHO toolkit has 4 steps that include asking the key question, identifying existing data sources, summarizing data and local context in order to make sense of the data, and then it ends with developing an action plan. So we'll get into these 4 steps in the next slides. Next slide. So to start, we'll identify key program problems and related questions. And I know from experience, it's tempting to dive right into data collection. And I've definitely done that before, but it's so important to sit down with your teams and really think through the process and make a plan. We include this as step 1 to triangulation, but honestly, this would be a step that you'd want to do no matter what, right? Before you start collecting or analyzing data. You'll want to work with the in-country partners you're supporting to ensure that the scope of the analysis has been well defined. You want to sit and think through how you plan to use the data to answer the questions. Is it to inform local program planning, or is it to inform larger policies and regulations? And an important point here is making sure the questions are answerable and actionable. As with any analysis, you don't want to get to the end and have a lot of data that you've collected and analyzed that don't fit together and can't tell a story. That's not a fun place to be in. And again, from personal experience, it's important to map this all out from the beginning as much as possible. Then, as always, you want to engage your local teams and stakeholders. Make sure the question that you're asking is truly actionable and useful in the setting. You want to engage a variety of relevant stakeholders from the beginning, reviewing examples, brainstorm, facilitate group discussion. The WHO guide suggests that good criteria for identifying a data triangulation question include that the question is important, answerable, actionable, appropriate, and feasible. The next step then will be to identify your data sources. And here's another place where I just think it's really important to talk to your stakeholders. Stakeholders can often provide a great overview of what data sources are available and regularly used and help explain the differences between them and identify strengths and weaknesses. But don't forget to also speak with stakeholders outside the MNCAH realm. There are often so many sources of data that we don't even think about when we're coming from the health perspective. A lot of times from budget or finance, logistics. So when identifying sources, just encourage your teams to try to identify all relevant sources, get an idea of how easy they are to access and to be compiled, and think through the strengths and weaknesses of each source, and consider documenting your list of sources for the future. And this is important. If you have ever stumbled across a list of secondary data sources that exist for a given population or time period, it's like finding a unicorn, like winning the lottery while holding a 4-leaf clover on top of a pot of gold. So basically all the symbols of extraordinary luck in my culture put together. These lists are so helpful to other researchers and programmers, but even for yourself and for your teams to reference back to if you need. And while these lists that you make and catalogs of secondary sources, they're not current for very long as new data sources always pop up, they are at the very least just a really good starting point for anyone. Next slide. So at this point, it's helpful to encourage your teams to think through the kind of data they want to use, or more specifically, what they want to use it for. Are you trying to provide context around your health facility data? If so, you probably want to consider diverse types of data like we discussed before. Your conflict or your weather data, budget data, or data collected, some data from household surveys. For example, you could look at malaria incidents in the facility and also pair that with BedNet ownership data from a household survey. If you want to support specific findings from routine health data, you may want to consider more similar data, particularly if it's collected using a different methodology. That independence is useful for assessing and addressing limitations of different data sources. For example, If you wanted to look at trends in diarrhea incidents over a given time, you could look at number of cases in a facility and compare that to reported cases of care seeking for diarrhea from a series of household surveys like the DHS. You have to be careful because the source of the numbers is different and they represent different things. One is self-report of seeking care, another one is, clinical diagnosis of things. But if you are trying to get an idea of generally of trends over time, you could pair these and look at them. Since we're talking about being careful, it's also really important to make sure the data you're triangulating represent the same time period and geography as much as possible. Similar time periods and geographies are always ideal, but if you're triangulating data for things that are seasonal, like diarrhea or malaria, it's even more important so that you're comparing apples to apples, as we say. Next slide. So then to round out the 4 steps, you want to next summarize the data and the local context and encourage your teams to do so. You can do this by assessing the data quality. You want to check for completeness of a data source and internal consistency, evaluate trends across data sources, the place and time, and incorporate context and local knowledge. Your local teams are the ones who can tell you about that nursing strike that closed facilities for a month or other contextual factors. Use the findings to brainstorm multiple hypotheses to explain your findings, and then be very, very honest about data limitations. And I think a lot of people stumble here because they think documenting all the limitations will make people question their data or results. And at least from my experience, I can tell you the opposite is true. When I don't see limitations, I question the data more. All data is faulty. There's almost always missing data or errors or something. So when I see a good long list of limitations, I know someone has really thought through the possible shortfalls and biases and has acknowledged the effect that they could have. So then you want to develop an action plan for disseminating your information. Sit down with your comms people around the table and work to generate simple key messages for your target audience. You want to tell a story with your data using visualizations and make sure there's a logical flow to the story. Case studies are a nice way to do this. And then put forth actionable recommendations based on your triangulation results. And don't forget to validate them with your stakeholders. Can you advance one, Dakota? Good, thank you. They know the context better than anyone, and they can tell you if what you're recommending is feasible or what you should prioritize. Next slide. Et voila, you have triangulated with your team. Congratulations. The WHO guidance also provides a few more slides on tips and tricks that you may want to check out, as well as this table of MNCAH program issues that could be improved with triangulation. Estimates of target populations is a big issue. We've been looking at that with immunization coverage and trying to triangulate all sorts of different estimates from different sources. But also looking at MNCAH program performance and impact of external events on MNCAH service delivery. I mentioned nursing strikes earlier, but obviously, COVID-19 is another disruption associated with changes in service delivery, and working with triangulated data can help explore those as well. So in summary, triangulation is an important tool and approach in data analysis, and one that may come as second nature to many of us. But I think thinking through it and actively planning out your question and purpose for triangulation can really help reduce the amount of unnecessary data collection and analysis that you do, and help ensure that you're working toward answering your question. Next slide. So with that, I want to shift briefly to discuss supporting data analysis with your partners and teams. And just to note, of all of the topics in this WHO toolkit in this series, we'll probably give this one the least attention. And we'll focus mostly on the planning side of things with analysis. But if you're looking for more, I really encourage you to refer back to the WHO toolkit and some of the other resources we'll discuss in a few minutes. Our presenter, Jean, also covers analysis of routine immunization data in his presentation. Next slide. So, what do you think of when you hear the word analysis? I know I think of statistics and complex equations and the like, but what is it really? And most simply, it's the process of transforming raw, unprocessed numbers or measurement or even text, known as data, into information, which is organized, processed, and structured. And that transformation process gets us one step closer to the ideal outcome of evidence-informed decision-making. Next slide. Next slide. Thanks. So you see in this slide a number of key public health measurement concepts that are presented in the WHO toolkit and guide. Causation, association, correlation, as well as statistical terms and concepts like ratio, rate, proportion. All of these are likely terms you're familiar with, and when supporting teams with analysis of routine data, it's important to know not just what these terms represent, but to think through how they can and should be used and what form of analysis is most appropriate for your data. And the best way to step back and think through what is most appropriate for your data is to make a plan for your data analysis. Next slide. So how do you support teams to plan for data analysis? How do you get your teams around a table, smiling like this, working on a plan? Well, first, I would recommend bringing chocolate. That's tip number one. But then I'd recommend talking through a few steps with them because planning makes everybody smile. So first, make sure everyone is on the same page about why you want to analyze the data. Why is it required? What question do you need to answer? Who is the target audience for the analysis? And once you align, work with them to outline a data analysis plan. Next, you want to review available data and indicators to identify and understand the indicators of interest for the analysis. The purpose of your analysis is important in identifying which MNCAH indicators you will use. Make sure everyone on the team understands the indicators. Make sure they understand what exactly is being measured, what the numerators are, what the denominators are for calculating the indicators, and what their data sources are, and even what format they're in. If you plan to make comparisons or assess progress over time, you want to, where you can, identify targets or baseline values where you can. And then identify the denominator data and its source. And if you have to, you have to estimate where needed. Then finally, step 3, prepare data and plan for analysis. Make sure you take a very intentional pause here. It's hard. Everyone wants to dive in, but taking the time here will save you time later. Look at the information you collected in step 2 and review it holistically together. Look at those quality issues and discuss them. Think through how you might mitigate or address those quality issues. Then you want to download, organize, and consolidate your data. If you didn't already take a close look at the format of your data in step 2, now is the time to do that. Make sure it's in a format you can work with, and if it's feasible to conduct the type of analysis you're planning. Then take a closer look at the data quality. And this is such an important step, particularly with facility data. I think in almost every presentation in this series, you'll hear presenters talk about data quality as a challenge. Take this time to review and adjust data quality where needed and document any adjustments you make in the original data set. You also want to make sure that you keep the original unadjusted data as well, so you can always just look back and see how they're different if you need to. So then you've set yourself up to begin analysis. And again, not going to go into that in greater depth, but the toolkit goes into a bit more detail. And it covers things like equity analyses, and that kind of thing. But we won't have time to cover that in today's session. So I really urge you to refer back to the toolkit for more information on that. Next slide. So before we head into the exciting presentations, I want to take a few moments to highlight some of the resources that are available on triangulation and analysis that may be useful in your work supporting these efforts. A few of these are immunization specific, but if you have other examples of good resources, particularly those available in French or other languages, please feel free to share them in the chat. Be interested to see. Next slide. Oh, here, we're here. Nope, you're good. Go back. Sorry to go to. As noted earlier, triangulation and analysis are covered in modules 4 and 5 of the WHO toolkit, where much of the content from today's presentation was sourced. So you can always review that material. Next slide. The toolkit is really nice. It includes useful exercises that can be used with teams to work through concepts like triangulation and analysis of MNCAH data. There's a nice facilitator's guide that helps you to guide teams through some of these exercises. Next slide. Then, in terms of triangulation, there are a few useful resources I wanted to highlight. One is a brief on triangulation of immunization data that outlines different immunization tools used at the health facility and how they can be used together. It's a very simple, short document, but it really does a nice job, I think, of presenting the concept of triangulation in a succinct visual manner. And it's also available in languages other than English, which I hate to say is hard to find. You can find it in Spanish, French, and Portuguese. Next slide. Adriana will also talk about this next resource in her presentation, but through the UIFHS project, JSI developed a Microsoft Excel-based immunization data triangulation tool with 5 regional health bureaus in Ethiopia. The tool triangulates immunization service statistics from DHIS2 with supply chain data from the Logistics Management Information System to produce ratios that can reveal data quality issues such as overreporting or programmatic issues such as consistent understocking of vaccine and supplies. The materials are available as supplements to an article published in Global Health Science and Practice that describes in more detail how the tool was developed and used, and some of the findings from the key informant interviews that aim to understand the feasibility, benefits, and challenges of using the tool. So all of these resources are available, but I do want to note, given the emphasis that we put on context for triangulation earlier, that this tool was developed with the Ethiopian context in mind, so would need to be heavily adapted to use elsewhere. Next slide. The next resource is a more general training toolkit that USAID and Measure Evaluation put out a while back. It is not MNCAH specific and it's a bit dated, but for basic analyses, things don't change too much over time. So the current WHO toolkit draws from this resource, so you'll find some of the content repeated, but this measure toolkit also includes job aids that you could use with your partners to help support basic analysis. It also has a lot of hands-on exercises too, in case you're looking for that, but it's only available in English, which is too bad. So if you have good resources, like I said, particularly those that are available in other languages, do share, and perhaps we could add them to the annex of this slide set when it goes up on the website. Be nice. And with that, we conclude the first presentation on the background material. I'd like to now hand things over to my colleague, Adriana Almagnana, who is a Senior Technical Officer for Immunization at JSI, to talk about her project's experience working on data triangulation for immunization in Ethiopia. Adriana?
Thanks, Emily. And thanks to everyone for joining this session today. Today I'll be talking about an experience that we had on a JSI project in Ethiopia to establish a data triangulation process comparing immunization program data and supply chain data. And we'll talk also about some important implementation lessons as well. Next slide. Great. So just a little bit of background first on kind of our whole process. Next slide. So in Ethiopia, the ministry's expanded program on immunization, or EPI program, they have administrative immunization program data that's typically reported in DHIS2. There's also a mobile-based system called Embrana that was being used as a logistics management system, and this recorded immunization supply chain data and was managed by the National Pharmaceutical Agency. So overall, what we were seeing was that there were some persistent challenges with timeliness, with completeness, with quality of immunization data, as well as just overall performance of the routine immunization program. We also were seeing, related to the data, that these data were being reported through different systems, through different departments, and the coordination and data sharing between those departments was limited. So all of that basically meant that, what we were seeing was that immunization program staff, particularly at the subnational level, they were not always able to look at or use supply chain data in their decision-making processes, and that the review and the use of data overall towards program improvement was not always consistent. So these were kind of, some of the challenges and the context that we wanted to try and tackle. Next slide. So what we did was hold a consultative workshop with different stakeholders to discuss. And, really what came out of that was an agreement that there was a need to develop a regular process for triangulating data. So what we did was come up with just a short list of indicators that the group wanted to be regularly tracking, and in order to make it feasible and be able to kind of look at performance and analyze on a regular basis. So once they had kind of chosen their few indicators, we also worked to develop the interpretation of those indicators and to come up with suggested actions depending on that data. So just to kind of look at the example here of what really we're talking about. One example is, if you had the doses administered plus all of your stock on hand for the previous 3 months, and you compare that to how many doses had been issued, over time, those numbers should basically be equal. And if they're not, if, for example, the ratio is higher than 1, then you know that this is going to indicate some kind of data quality issue or perhaps over-reporting of doses administered. So you may have some suggested actions for that, which might be to really kind of investigate the reasons, that you're seeing this at the district level and provide some support, whether that's for recoding procedures or, incentivizing accurate reporting versus high reporting, that sort of thing. So, basically what we did was kind of map this out for each indicator to really help facilitate the interpretation and the action based on the trends that you are seeing in the data triangulation, in the triangulated data. Next slide. Great. So this graphic, and we'll dig into this graphic a bit more in the next few slides. This shows just the overall regular data triangulation process that we had laid out. And again, this was something that was done on a monthly basis. So let's take a look. Next slide. Great. Wonderful. So First, every month at that regional level, we would get the vaccine supply data from that system, the immunization program data from DHIS2, and they were sent to the immunization or EPI focal point in this activity that we were doing. The immunization focal point was kind of in charge of the entire activity, so they were managing this process from start to finish. Next. So then that immunization staff would import the data that they received into an Excel tool that we had developed to help merge the data and to facilitate the analysis. And then, what I see as kind of the most important part of this process is number 3, where the group actually meets. We made a very intentional effort to create a cross-departmental committee or working group that was looking at this data triangulation. So this was really the focal points for immunization, for supply chain, and for DHIS2 at that subnational level. So they would meet together, look at that data together, discuss, and then determine what actions are needed. Next slide. Great. So after the meeting, then the assigned staff would carry out those action items. Depending on the problem or the issue that was being seen in the data, the action items might have been different, right? So maybe some may have been kind of digging deeper into the data quality or the completeness of reporting, while another action item could have been conducting supportive supervision at the lower level. Right, so different actions were being taken. And, the idea here was really that the triangulation analysis was driving concrete actions that were happening at lower levels. So this really allowed managers to better pinpoint or prioritize their support in order to improve the management of services as well as the delivery of immunization services. Next slide. Yes, and then of course, lastly, just to say that this cycle would then repeat again the following month, and continue. Next. Great. So, we supported the rollout and the implementation of this monthly process in 2 subnational areas of Ethiopia. And after several months of implementation, we documented what we were learning through some key informant interviews, as well as a review of the tool, the data, and the meeting minutes. So let's look at the findings. Next slide. Great, next slide. Thanks. So I'm just going to share some selected findings, and then we'll get into some implementation lessons. As was mentioned, this is written up in a journal article, so we can share the link to that. So some findings. So firstly, committee members were interacting with the data and with each other often, and they were examining the data holistically. So these were folks that maybe were not necessarily in meetings together all the time, but this was kind of fostering that sense of collaboration, and as well looking at that data together. Another thing that came out strongly in interviews was that this idea of kind of simultaneously reviewing immunization coverage as well as the supply data was a somewhat new process, and there was really a recognition of a value add there. So there was a lot of value in kind of being able to look at that together. One of one of the implementation areas demonstrated rapid uptake of the tool and approach. So they were regularly using the tool for decision making. They were having consistent meetings, and over time, they were showing kind of increased mastery of the different processes, whether that was importing the data or kind of checking for errors, et cetera. The second area where we implemented this experienced a slower rollout. This was back in 2020. So in that area, they were experiencing they had some recurring conflict that was occurring, as well as some waves of COVID-19. And so these issues really affected the functionality and the performance of the region's immunization program as a whole. And then, of course, also caused a delay in the implementation of this particular activity. But this was kind of something that was affecting more broadly. And what we found was that reporting to these data systems had lapsed, particularly on the supply chain data side. So there was some steps taken to improve data availability prior to starting this triangulation process, just to make sure that we had enough data available to look at. So this was really an ongoing process. There was some work that was done up front, and then it was something that continued. And what we really did was encourage those subnational managers to just start with the data that they did have. And we'll talk more about that as we get to the end. Next slide. Great. So I'll just touch on some documented outcomes, just some couple of examples from this pilot activity. One was an increased number of outreach sites. So there was an analysis that was done, looking at they saw that they had low coverage in a certain town. However, they had perfectly adequate vaccine supply. So the action that was taken was that the immunization team met with the district and really tried to identify some of the issues of what was going on. And the outcome of that was that they were able to come to an agreement and launch additional outreach sites to be able to reach more folks in the community that were not as close to the health facility. Another documented outcome was a revising of a target population in another area. So they were seeing that there was some poor performance. So the action that was taken was a supportive supervision visit. And basically what happened was that they realized that some rezoning had happened, but they weren't accounting for this in their planning for immunization sessions and the rest. So they were able to revise their target population, adjust their microplan, and move forward to take this into account. Next slide. Great. And I want to talk about some lessons learned, particularly because this was truly a learning activity. And there was so much during the course of implementation that we did learn that I think will be helpful. Next slide. So first, around the area of kind of establishing regular processes for using triangulated data in immunization. So first and foremost, triangulation can foster better coordination among health staff with different professional roles. I can't stress this enough. This is so important to be able to analyze data from different perspectives. You're getting folks into the same room, and then you're able to encourage that group problem solving, including with others that maybe you're not in meetings with every week. So it's so important. Second is the regular availability of data is important to fully leverage the benefits of triangulation. So it may seem obvious, but it is essential to ensure regular reporting of the data into those data systems, right? So what we really found is embarking on this triangulation process is that there still needed to be kind of parallel efforts to improve and sustain basic data availability and completeness, and to continue to prioritize that. And third, we found that subnational managers could use data triangulation to monitor issues at the district level. So um, we saw that in our implementation that it was really taken up as a kind of management tool, particularly at the regional level, so one level above district, and to really basically address problems that were happening at, for example, at the district level. And so it takes this kind of ongoing practice and support, but it really helped kind of pinpoint the support that needed to happen to districts. It was impossible for the regional office to do supportive supervision everywhere, for example. So they were really using this data triangulation data and process as a means to be able to prioritize where they needed to provide their support with limited resources. Next. Yes, and then a few lessons that we'd love to share on introducing tools and processes into health systems. The first, I think, will be familiar to all is designing with and for the users. So, from our perspective, data triangulation was kind of seen as this maybe difficult process or an ad hoc process. And what we really wanted to do was use this as a way that you could routinely be triangulating data to solve problems and to work towards performance improvement of the program overall. And to be able to make this a routine thing that we really had to kind of co-design it with the users from the beginning to really see, what was most important to them, what was that maybe the back end kind of work that needed to be done automatically. Some of those pieces that I mentioned around having some pointers for the interpretation of certain indicators or even suggested actions to take based on data. So as much as we could kind of do that work ahead of time, that's what we ended up doing. Second is manage change, of course, and encourage new practices through frequent follow-up support. I think this goes for any kind of change process. You have to be providing that regular mentorship and to really be troubleshooting technical issues that are during the rollout that come out, especially in the beginning, like they will happen. So being ready to provide that frequent follow-up support and then easing up as time goes on. Third is embedding implementation research into introduction processes. So when you're introducing tools into a system, we really felt that embedding the implementation research as we did was just so critical. It can provide so much valuable information on, what's working, what isn't, and then what do we need to do to adapt or improve the implementation and rollout. And fourth, last but definitely not least, was don't let the perfect be the enemy of the good. As I had mentioned before, regular reporting had lapsed just before rollout in one of our areas, and so this really negatively affected the data availability in this area. However, despite that limitation, we really encouraged the group to start analyzing the data that they had available, while at the same time working to improve overall data availability. So really the getting started with imperfect data that allowed the stakeholders to begin to work collaboratively and build those relationships, to increase their comfort and capacity with analyzing triangulated data, and to begin taking action to address the problems at that district level. Next. Great. And just to finish up with way forward and recommendations, next slide. So I'm just sharing some selected recommendations. This was in the end a pilot kind of learning activity, and we do need more information, including at more advanced stages of implementation over a longer period to kind of understand what regular data triangulation processes can look like. The approach that we took was just one approach. There's so many ways that you could think about introducing a regular data triangulation process. So, kind of understanding what different approaches could be and what might be most feasible. And then also more information on how data triangulation processes contribute to better programmatic decision making and better data quality. So really making that link between data triangulation and those kind of further outcomes that we're really looking for. And then finally, just some parting thoughts for anyone who may be kind of embarking on a data triangulation process or thinking about it, is one, to facilitate collaboration and decision making across teams and functions. So again, I can't restate how important that is to break down those silos. Make regular data routine, so promote that data triangulation as a regular process. Third, encourage attention to data availability, as we said, as well as to data quality. And then fourth, really focus on what are the concrete actions that we can take. We should not be doing data triangulation for triangulation's sake. It should be in service of solving some kind of programmatic problem or issue or working towards better health outcomes. Next slide. Great. And with that, thank you so much. And I will be sure to share additional resources as well.
Thank you so much, Adriana. And thank you for that wonderful presentation. A lot of really great concrete recommendations, tips, tricks, very, very useful for all of us. So thank you so much. If you have questions based on Adriana's presentation, please feel free to put them in the question and answer box. We'll take some time at the end to answer and discuss. And with that, I would like to now turn things over to today's final presenter, Jean Dorville. He is a data manager with MRHIS in Haiti and will be talking about his experience analyzing routine immunization data. Jean?
Merci, bonjour à tous et à toutes.
Thank you. Thank you. Hello to everyone. I'm Doel John Ronell, and I am a data manager at MRHIS. It is a pleasure to be here to present the way that we can analyze vaccination data, routine vaccination data in Haiti with the project MRHIS. Next slide, please. The project MRHIS, it is in Haiti. It is that has an objective to initiate technical support to 5 departments to eliminate data entry backlogs and to improve the quality of COVID-19 vaccination data, and also to support the implementation of subnational and national data review and use processes with a focus on the 5 project departments. So the Northwest, the North, the Northeast, South and Arbanite. Next slide.
Suivant, s'il vous plaît.
Next one, please.
Merci.
Thank you.
Maintenant,
Now,
pour atteindre les objectifs,
to be able to get to meet the goals, MWrite, the project, they had several activities, such as supervision missions, data correction and validation workshops, as well organizing data review, analysis, and interpretation meetings, this at different levels through the UCNPV and the UEP, which are ministry or organizations. And we also have daily activities such as to be able to analyze the data at the department level. And also we have capacity building of departmental managers in data interpretation and analysis in partnership with CHISU, which is with MWrite Haiti. And so there were 124 were trained. But also there were some validation activities in DHIS2 in the project MWrite. The government already used a system to register the patients, but in the instruments, there was some error, there was some data that were not entered. And with the arrival of the project, MWrite is trying to validate that are in the registry, that are in the sources, so help the registration of the data that are not in the system. And so there's a lot. There were 51,114 records that were corrected and 62,265 records that were entered through the registry. Next slide. Now, the data analysis, that is a process. It consists of inspecting, cleaning, transforming, modeling data to uncover hidden insights and make informed decisions, which will allow to make decisions, to make informed decisions. And these could include identifying significant, meaningful data and establishing relationships between them, to use statistical techniques to understand trends and patterns in the data, and to visualize data for a clear and easy to understand presentation. So you can go to the next slide. Now, in Haiti, we tried to have the process of vaccination with the data, and that is good. But these are the different data points. And so it comes to the department level. There's one, the one that are entering reports in the DHIS2 to make the coherence of the data better. And they are put into the system DHIS2. And that is step number one. The data clerk at the departmental office verifies and enters the report. And number two, data validation at the institutional level. So before, it was just to not prevent the departments to be prompt and acceptable in the eyes of the ministry. And this is why it is it
la
is
concordance des données, on
the data must be verified. But after that it is entered, once the capture it is reality, the statistic in the department to talk about the monthly reports that are sent, and there are always cases, and these are on place, and they are corrected when there is a copy that is in the institution and that is sent to the direction, and it is corrected. It's during step 2. Now in step 3, there are some data that are corrected after the validation of the DHIS2. After being validated, they're corrected again, that were put in the analysis. Now that they are in, so they've been verified, they've been corrected, and now the data is ready to be exported. So the data is exported from DHIS2 to Excel, and then they are processed in Excel. And that is step number 4. And in step number 5, they are downloaded to Power BI, and that is what is used to analyze the data. So Power BI to transform the data if that is necessary, and then we create visuals which are shared through Power BI service, or to export them in a PDF file to be shared with the different managers, and to try and see or to analyze the data to be able to make decisions, key decisions. Next slide. Now, so the analysis goals. So what are the managers, what are they looking for? That they're normally and one of the analysis goals is to observe trends in vaccination coverage in the last between current and previous years, and to view vaccination coverage by municipality and institution, to calculate review dropout rates by institution, and it also to compare 0 dose and under immunized children in the current period with the same period in the previous year. So that's Penta 1 and Penta 3. And that is also to the trend in the proportion of fully vaccinated people. But in all of that, generally the managers, they look at for the beginning to analyze the zones that have a good access point, and that they have a good service utilization of vaccination. Also, through the data, the managers look for being able to define the zones and criteria to prioritize the zones, to know where to carry out interventions or to accelerate vaccination. And normally there's 2 antigens that are taken into consideration, Penta 1 and Penta 3, that are identified for the public to be able to evaluate the entire program. For example, if one zone has a good access point, that is done through the coverage of vaccination Penta 1. If there is a zone or an area that has a vaccination of Penta 1 that is less than 50, we consider that has a very bad access, a service of vaccinations. So it is between 50 and 69. We say that has a bad access to vaccination program. And so we put it in yellow. But if it is 1, it is
cette zone a
we
un
say that
bon
that zone has a good
accès et
access,
cette zone se met en vert.
and that
Mais
is, they
à
are put in
part de la
green.
couverture en Penta 1,
So
on
Penta
considère
1,
aussi,
we also
ou bien on
consider
compare
that we
avec le taux
compare it
d'abandon. Le taux
to
d'abandon qui se
the
calcule
rate.
entre Penta 1
So
et
that is
Penta 3
calculated
pour
between
essayer de
Penta
voir s'il
1
n'y a
and
pas
Penta 3.
déperdition au
If
cours
there
de
is
la route
not
pendant que l'enfant
any
prenne ce
loss,
vaccin, s'il n'y a pas
if
abandon
there
au
is
niveau
not
du calendrier vaccinal.
abundant
Maintenant,
in
si le taux d'abandon est
the
inférieur
vaccination
à
calendar
10%,
at
on dit qu'il
10%,
y a
we said
une
that
bonne utilisation du service
there is a good
de la
service
vaccination.
utilization of the
Si le taux
vaccination.
d'abandon
So
est
if the
supérieur à
dropout is above
10%, on considère automatiquement qu'il y
10%,
a
we
une
consider
mauvaise
there is
utilisation
a
du
bad
service
use of
de
the
la vaccination.
immunization service.
Maintenant, tout ça, c'est pour
So
essayer
all of
de
that
catégoriser
will
les
help
zones.
us categorize
Il y
the
a des
areas.
zones catégorie
Some
1
areas are
qu'on
under
met en vert,
category
c'est
1
lorsque
in
la
green
couverture
when
vaccinale
the
Penta 1
coverage with
est
Penta
supérieure à
1
80%
is above
et le taux
80%
d'abandon
and
est
the
inférieur à
dropout
10%.
rate
On dit
less
que
than
cette zone a
10%.
un
So
bon
this
accès
area has a
et
good
une bonne
access and a
utilisation.
good use
C'est-à-dire, un grand nombre d'enfants commencent et terminent leur série de vaccination.
when the children are
Maintenant, cette
actually
zone se
having
met
all
en
the
vert. Il y a aussi les
vaccination
catégories,
doses.
la
Then we
catégorie
have it
2
in
qui est en
green.
bleu,
We have the second
où
area, second
lorsque
category,
la couverture
when
Penta 1
the
est
Penta
supérieure à
1 is
80% et le
above
taux d'abandon
80% and
est
the
supérieur
dropout
à
rate
10%. On considère que cette
above
zone a un bon accès
10%. We consider
et
it's a good
une
access
mauvaise
area
utilisation
and bad
du
use
service.
of the
C'est-à-dire, il y a un grand
immunization
nombre
service.
d'enfants qui commencent leur série de
We
vaccination,
have some children
mais
starting
ne
their
terminent pas
immunization
leur série de
schedule
vaccination.
without
Cela pourrait
finishing
venir
or
tirer parce que
without
lorsque
achieving all the
les
doses.
responsables analysent les
This
données, on pourrait
will
dire
be
que
seen when the
il y a un
rest,
mauvais
the
accueil,
manager
il y a une
are
réduction des
analyzing
vaccins,
the data.
il y a insuffisance
It can
de
happen when we
communication dans
have
le calendrier
a
vaccinal,
problem with
etc.
supply,
C'est ce genre de
problem
choses
in
que les responsables
communication.
de
So these
programme
are
essaient
what
de
the issues
comprendre,
that the
recherchent
managers need
lorsqu'ils
to
analysent
understand
ces données.
and
Il y a
solve
aussi
after
une troisième
analyzing
catégorie
those
qu'on met en
data.
jaune.
We have a third category
C'est
in
lorsque
yellow
la
Sorry,
when
Jean,
the pen.
sorry, don't mean to interrupt. Dakota, could you advance the slides, please? There. Is this the right slide? Or you're on the next one?
Non, vous pouvez rester là où vous êtes.
No, you can stay where we were.
Okay.
It was fine.
On voit
All
ça
right,
après.
thank you.
Okay.
Oui, la catégorie 3
So third category
se met en jaune, c'est
is
lorsque
in
le
yellow
Penta 1, la
when the
couverture
Penta
Penta
1
1 est
coverage
inférieur à 80%,
is
mais le taux
less
d'abandon
than
est
80%
aussi
and the
inférieur à
dropout
10%.
less
Considère que
than
cette zone
10%.
a un
And
mauvais
then we
accès, mais a
consider
une bonne
that
utilisation du service.
bad access, but a good
Maintenant,
utilization
comment
of the
on interprète
service.
cela?
So how do
Peu
we
d'enfants
interpret
ont accès
all this
au
data?
service de
Less
vaccination, mais
children have
beaucoup parmi
access
ces
to
enfants qui ont
immunization
accès
service, but among
acheminent
those who have access,
leur vaccin.
we need to determine which one will have the entire vaccination schedule.
Cela pourrait être dû à une insuffisance
So
de
we
services
see the different
communication,
reason, maybe
rupture de
problem
stock,
communication
insuffisance
issue,
des moyens de transport
lack
des
of
parents,
transportation
Mais
for
il y a
the
aussi
parents. And
une
there
quatrième
is
catégorie
also
qu'on met en
another
rouge,
category
et je
which is
pense
in
que c'est
red.
là que les responsables du
And
programme
this is where the
doivent
program manager
mettre
may
leur priorité.
focus their
C'est
attention
lorsque
to
le Penta 1
when the Penta
est
1
inférieur à 80%
is less
et le
than
taux d'abandon est
80%
supérieur à 10%.
and
Là, non seulement il y a un mauvais accès, mais aussi il y
less
a une mauvaise
dropout more than
utilisation
10%.
du
That
service de
then
la
we have
vaccination.
both bad
C'est-à-dire, peu
access and
d'enfants
bad
ont
use of
accès au service de
service.
vaccination
So there
et aussi très peu d'enfants terminent
less
leur série
children
de
have access
vaccination.
and do
Maintenant,
not
cela pourrait être dû
achieve
à
their
un manque de séances
entire
de vaccination,
immunization schedule.
rupture de vaccins dans l'institution,
So this may be
insuffisance des
due
moyens de
to
transport des
the
vaccinateurs,
stock out of
insuffisance dans la
supply,
communication avec la communauté,
bad or
mauvais
absence of
accueil.
communication, bad
Maintenant, vous pouvez avancer.
buy-in or any other reasons.
J'ai demandé à Grace
Slide,
d'ajouter
please.
un slide, il paraît qu'elle a oublié.
I think missing one slide. I'm sorry about that. But I wanted to show you, after everything that I said, through data, how the program manager prioritize the intervention area according to the data analysis and the category of area. We have the red, the yellow, orange, and green. The red zone are priorities areas, yellow are less priority, the blue one are average priority, and in green, no priority zone or area because there is no under vaccinated, under immunized children. So we are basing our analysis on this categorization and focusing on the zero dose children. So this is a snapshot that is come from a tool, MRHIS tool, to help the government analyze the vaccination data. And here for the COVID, we see different indicators. So it's specifically adverse event following immunization, EFI. We have the number of vaccinated people per municipality, commune, also number per year and number per professional sector. So we have different angle of analysis, and we have the different filters to do the research. Next slide, please. So this is the routine immunization data by antigen and department. We have Penta 1 and Penta 3, and we consider these categories to determine if a health facility offer a good or bad access, and if they are also dropout. And each department, district, and commune is using this information, analyze this information to understand if this area have a good or bad immunization service use and access. So they can really study and use this information per facility and per district. This is what we use to disseminate the information we collect that are available and that are available in the DHIS system. Slide, please. So what are the lessons learned starting from this analyzing of immunization data? We have different sources of information, and we need to find the data to be analyzed from the records and also identify where the gaps are. So for us, it is important to ensure a comprehensive data collection. And we really raise awareness with the program manager, but they don't always use the data analysis to make informed decisions. For this, we will need to more efforts, better use the data for decision making, and improve and scale up our training for this program manager, and also provide them with the right tools, analysis tools, and interpretation tool and analysis tools. Slide, please. So in terms of recommendation, so we need to make those analytical tools available to program manager, formally to ensure that program manager use and analyze immunization data and promote the use for decision making. We also need to introduce the digital vaccination register into our system to facilitate the collection and of the data and the longitudinal monitoring of the patients. This is very important to have available data, quality data, and expand our analysis regarding routine immunization. Slide, please. Finally, what is the impact of data analysis on vaccination? We were able to see that with the support of Momentum in Haiti, we have been able to better manage data quality and promote a reliable data analysis. We were also able to map areas with low and high vaccination coverage rates to identify priority population and risk population and have some awareness campaign. We were also able to triangulate vaccine consumption data with those of the administered vaccine. So we had the number of vaccinated patients, but we could not compare that with the number of vaccines provided. But with MRHIS, we were able to really triangulate this information, and we have a better approach, better understanding of the coverage and the use of the vaccination supply and the coverage of the priority and most vulnerable population. So I will end here. Again, we were able to develop our intervention in the more risk area, improve the quality of immunization service in Haiti, thanks to Momentum, MRHIS, and these programs specifically. Thank you for your attention. I'm here to answer any question if you have any.
Thank you very much to all of our presenters for your very insightful and interesting presentations. We had a good amount of questions in the questions and answers, and many of them have been addressed. There has been a few responses and some really interesting discussion over in the Q&A. But for now, maybe I will direct a couple questions to some of our presenters. And my first question would be for Jean, which is, what suggestions or recommendations would you have for others who are working with local partners or with ministries in order to help them analyze routine data?
Bon, généralement, je pense que
I think that my advice to be able to line up with the local managers to let them understand that you are there to help them, because generally there is some reluctancy to find the data and for the ideas to research, and so that let them know that you are there to help and that we are there to help progress things with them so that people can do better and to accompany them in this task. But normally it is the communication, the observation, and your capacity to propose certain things that will be able to help them actually, and that could more or less help them, that will help them in their work.
Thank you so much. And maybe for one more question, I will direct to Adriana for a question about your presentation with the UI FHS program, which focused mostly on program and supply data. Thinking back now, are there other types of data that you have considered or that you have used in your work that could be triangulated to help improve programming decisions?
Yeah, thanks, Zach. So I think another kind of triangulation that is common for immunization data, at least, is looking at surveillance data. So, for example, if you have cases of measles and looking at your coverage of measles in different areas. So I think that's often also quite common. I think regardless of what data you're choosing based on your question, I think some of the same principles apply around that process, right? So kind of that four-step process that Emily went over in the beginning of, asking your key question, getting your data sources, getting context and analyzing, and then making an action plan. And that whole piece around the process is so important, regardless of whatever data you're looking at. Thanks.
Thanks, Adriana. I'm looking through and I don't see too many more questions. I think we are coming up on time, so I will hand it back over to you, Emily, to wrap us up.
Great. Thank you so much, Zach. So let's see. I just want to say, next slide, please. Advance one more slide. Okay. All right. Sorry, y'all. So thank you all for the wonderful presentations today, to Adriana, to Dorviljean. Lots of great questions, lots of great discussion. I saw a lot of some comments in the Q&A about interpretation and use of data and how important that is. And I think that's a great segue. Our next session next week will focus on data interpretation and use and how to support your local teams to use your data and interpret it well. We'll have some presentations from Momentum Country and Global Leadership. So that should be a really interesting presentation next week. So I invite you to attend. You can register using the same link as you did for this session. And yes, just finally, next slide, a thank you to our presenters, our interpreters, everyone who is helping to support the webinar today. We appreciate your attendance and your engagement. So thank you all and hope to see you all again next week.